welcome to the Adults and Health Scrutiny Review Board. Today is the 3rd of October, 1 minute past 6. We'll just go through the agenda as is. With the only apologies I've received is from Councillor Jerry Pearce. Any others?
No other apologies, Chair. Thank you.
Thank you. There are no late items that I've been informed of. So we'll go on to declarations of interest. Are there any declarations of interest from members? No, excellent. Okay, so we'll go on from the meeting, the minutes held of the meeting on the 4th of July 2023. Have we got any comments on those items? Page 1, 2, 3, 4. Any changes, any comments? We're happy, can I get those passed? Lovely. Thank you very much. Can I have a mover for those? Do we need a mover for those? Technically? Councillor Repton, are you happy to move the minutes from? Yeah. Thank you. So we'll go on to item 5 then, which is the Derby City Council's approach to disposable vapes, and we've got Robin Jewis and Donna Dowse. Excellent. Thank you.
Sorry. Good evening, everyone. I'm Donna Dowse. I'm the Trading Standards Service Manager for Derby City, and we've been asked to give a presentation on Derby's approach to disposable vapes. So I just thought it would be useful to run through a bit of the legalities behind disposable vapes at the moment. So, Dom, if you can move on to the next slide, please. Thank you. So the technical name for vapes is nicotine inhaling products or e-cigarettes, obviously more commonly known as vapes. To be legally sold in the UK, they have to be registered on the MHRA website and published on their website. So it's a registration and licensing scheme. There's got to be a UK responsible person for the import and distribution of vapes in the UK. And this must be on a leaflet or label with the product being sold. Device capacities shouldn't exceed 2 millilitres in terms of the nicotine liquid contained therein, which is approximately 600 puffs. So if there's anything over around 600 puffs, then it's unlikely that it's legal to be sold in the UK. Nicotine containing e-cigarette liquid cannot exceed a strength of 20 milligrams per milliliter. So in a disposable vape, for example, if it's a 2 milliliter capacity, you're likely to have 40 milligrams of nicotine in that particular product. It can be expressed as 2% or 0.2 grams, and any products labelled as 5% are illegal. It's also illegal to sell e-cigarettes to anyone under the age of 18, and various organisations are looking to get the laws changed in respect of vapes, including banning disposable vapes. So there's lots of people looking into that. The legislation we enforce in relation to vapes comes under the Tobacco and Related Products Regulations 2016. So that's just a bit of background on the legalities around vapes and how they should be sold in the UK. I know this is an adult health scrutiny board, so I'd like to bring in Robin, who we've been working with in relation to some of the matters concerning disposable vapes, if that's all right. Thank you.
Thanks. Thank you. And just to think about vaping and its place in it's a really complicated subject area, isn't it? So we have vapes which are legal. And then we have legal age of sales of those vapes. So vapes which are legal and can be sold to people who are existing smokers to support them to quit smoking tobacco. And there's really good evidence around the benefits of that and the effect that can have on improving health. The evidence around then quitting the vape is a little bit less certain. But if somebody is really struggling to quit smoking and can transfer to a vape and continue to try to quit that, it's got to be a better option for their health than to continue to smoke. But then we have the other two groups. So we have the group which is around the legal vapes and underage sales, and then we have the illegal vapes. So the legal vapes and the underage sales we are very concerned about, particularly because if young people are taking up vaping and they're not smokers and they're not addicted to nicotine, then this can encourage ongoing nicotine addiction. And we are aware that there's a number of tobacco industry companies now looking at becoming smoke-free, and some of them even talking about it on their website. So we know that there is a really strong commercial drive as well around the development of offering vaping as a commercial alternative, if you like. So there's really strong drivers there. And then obviously all of the work that Donna does around the illegal vapes. So we've got concerns around illegal vapes and the potential contents of those vapes. But then we've also got concerns about the impact of some of the contents of the legal vapes as well, which is some of the work that you've been doing with the university, isn't it, as well? So we've been working really closely with Donna and the team, and also with the university, on understanding the health impacts. And the university have particularly been analysing some samples of illegal vapes for us to assess what's actually within them and whether we fully understand that. And they're also looking at, from a legal vape perspective, the flavours and what impact that might have, because we know that there are some flavours being promoted that are specifically attractive to young people, bubblegum and all sorts of other flavours like that are clearly marketed at a particular age group. So they are doing further work to understand that, and we're not there yet with that at all, but it's just part of our work to fully understand the issues. So from our perspective, we need to make sure that Donna can be supported to reduce the sale of illegal vapes, and that we can work with young people and with schools to help them to have those conversations with young people and to explain to them the risks of vaping. We've also got a tobacco control needs assessment and a whole stream of work around tobacco control, and this vape work is being seen as really part of that around nicotine addiction. Carry on, Donna.
And sorry, Don, we're 2 slides. No.
Sorry,
the
I
next
was.
one after that, please. Thank you. Oh yeah, thank you. Sorry, speak. So we've already touched upon the fact that it's illegal to sell vapes to people under the age of 18, but it's currently not illegal to give them away as free samples, and the government's trying to look at closing that loophole at the moment. So far, we've received 36 complaints relating to the underage sales of vapes, and we've visited all those premises so far. And that's going to form part of a BBC documentary called The Defenders at some point in the near future, to highlight the issues we've got around the underage sales of vapes. So once they're visited, they're either advised or there's further action taken, and that's what we look at in terms of the propensity of selling, past history, things like that in relation to the shops that we do visit. We actively encourage a Challenge 25 policy. That's been ongoing since the underage sales of alcohol and tobacco anyway, and that's just introduced and further promoted for the underage sales of vapes. We've also responded, because there's such an issue or perceived issue with the underage sales of vapes, the government has done a youth vaping call for evidence questionnaire, and Derby City Council have responded in respect of that in terms of what we've learned around the underage sales of vapes. So they're collecting evidence on what the current issues are surrounding this particular problem. Can I have the next slide? And we've currently got one funded disruption officer who's visited 34 shops that we've seized vapes from. We've issued 3 warning letters. There's currently 3 ongoing criminal investigations in relation to the illegal sale of vapes. And I don't know if you're aware, but there's lots of retail premises, and it stems from the illegal tobacco type visits that we do, where there are concealments within the shop with electromagnetic kind of gadgets. Where there's a shop close by that had one that was a floor tile, and it raised up and it had all the illegal product within that particular floor tile. So they're getting very creative as to how they hide these products. And normally we rely on tobacco dogs to find these concealments. And so I think at the moment there is training with dogs to actually locate the illegal vapes as well. So it's just a matter of catching up with with what the criminals have engineered already. 5 shops have closed. One was using a closure order. That requires the input from schools, the police, around the underage sales of vapes. That was in Spond and that's been publicised. So that was some good work that came out of that. We've executed 6 warrants so far. And bearing in mind these figures are increasing all the time, it's daily work that we're doing. POCA, so the Proceeds of Crime Act, we can follow the money and we can restrain money, we can seize cash and take that side of the criminality away from those that are dealing in illegal products. And we've had to purchase an additional storage container to store all this illegal product because we currently haven't got the capacity to store it in our normal evidence store. So there's a lot going on around disposable vapes. So next slide, please, Dom, if you don't mind. So there's just some figures there on what we've done so far. So 32,000 vapes and £6,000 have been seized from a vehicle. That was in Nottingham, I believe, but it was a Derby-based trader, so that came to us. The retail value on those vapes is £59,333. We've had 4,395 vapes seized from shops, and again 5 shops have closed, and the retail value from the vehicle was £432,000 just from one van. So there's quite a lot going on in terms of the illegal activity. Bearing in mind this is not the requirements that we also have to check in terms of the legal vapes being sold. So this is over and above the legal ones, yeah. Next slide, please, Dom, if you don't mind. So there's just some statistics there in relation to poisonings from the ingestion of vape liquids, mostly reported in under 5s in 2021. This was 82 children, and that's come from the National Poisons Information Service. There's 15 fires resulted from vapes, and that's due to the batteries that use the lithium batteries. So there's a product safety issue in respect of these particular items. Explosions can occur in the mouth, hands or pockets and cause severe burns and injuries requiring prolonged medical treatment. And so the work we're doing is taking these products off, because there will be safety requirements that the legal products have to comply with, but the illegal ones, they just don't care how that's put together. The 0% nicotine inhaling products, which don't have a nicotine content but still a product safety issue, they're governed by the General Product Safety Regulations, so that's still a matter for trading standards to deal with. So if we get any complaints, that would have to be investigated from that aspect. And we've seen reports now of where there's customisation of vaping products, which can include drugs such as cannabis with the THC element to it. So there's reports of that also going on. There's also the recycling issue and the waste from electrical and electronic equipment regulations. So there's an environmental impact with these products as well, which we've been looking into. And just a bit more on what Robin touched on. Next slide, please, Dom, if that's all right, in terms of the research, education and messaging. We have been working with Derby University on the testing of counterfeit vapes. Sorry about the picture. And hopefully he will have a report on that soon. He's already doing a scientific paper on legal and non-compliant vapes, and what I mean by non-compliant vapes is those that are over capacity, not necessarily counterfeit or fake branded. And he's asked trading standards to have an input into that scientific paper from our perspective, so that's what we're working on at the minute. I've also been working with the Derby media students to try and get some social media messaging around discouraging young people from vaping. We've kind of lost touch in recent months, but I'm hoping to get in touch with the lecturer that actually worked with me to get this off the ground, and some of the students put some really good presentations together, so it'd be worth pursuing that to get these messages out to students and maybe help some of the schools. I don't know if you're aware, but there are reports of vaping in primary schools as well as secondary schools. And also there's gang warfare been reported in relation to school-aged children on the supply of these vapes, and there's also reports of grooming children. So it's not just adults that are being impacted by these particular vapes as an aid to quit smoking. It's children that are being affected and becoming addicted to the nicotine as well. So we're educating the public through media messaging, working with the BBC. We did an ITV report and a BBC's Midlands report on the work we were doing with the university and vapes in general. We do talks to the Royal School for the Deaf on underage sales, and that includes vapes and the promotion of a citizen card. Like Robin said, we're working with yourselves and the smoking cessation team, because they're looking at options to deliver vapes as an alternative to smokers, to smoking, to help their current clientele quit smoking. So we're working with them to make sure they purchase and source legitimate products and know what to look out for, and have a Challenge 25 policy themselves, or some form of reporting or recording method as to who they're supplying these vapes to, as well as looking at that recycling aspect of it in terms of the climate and environmental impact. And we're also having an input into the tobacco control needs assessment report that we do with Carrielle and the colleagues, and there's a strategic and wider kind of issue that we work on in terms of Derbyshire, is it, and some other authorities, that we can collectively get best practice ideas on how to take this forward and tackle the problems that we're currently facing. I think that's it. If you've got any questions, sorry, there's a lot going on there.
Thank you, Councillor Repton.
In terms of the storage facilities, what happens and when after that? Because obviously we don't store it forever. And also under the Proceeds of Crime Act, I see that £6,000 was taken. Is there any way that we can recycle that money or other legal or safe resources back into the empty coffers of the NHS or the council?
Thank you for your question. So in terms of the storage container, that depends on the next step. So if it's an investigation, we can't dispose of it until after that, and then we have a disposal method for that in terms of recycling, and there are certain companies that we can use, or even our own waste recycling facilities at the City Council. Until a prosecution has been done, or until we can request forfeiture, because it's seized product, it's still the owner's items, so we can't dispose of it until we've taken some form of action. Does that answer your question in relation to the storage aspect?
So you have to wait until after the prosecution?
Yeah, or further
action.
Have you got any
examples about when a prosecution you waited to that? What happens to the actual things that are disposed of, like money, for instance?
But I'll get onto the POCA side of it next, if that's all right. But yeah, the prosecutions are kind of interlinked with illegal tobacco and serious organised crime, so they take quite a long time to get through. So the prosecutions we're currently working on are the first in terms of the vapes investigations that we're doing. So they're still in the process of being investigated. In terms of the proceeds of crime money, again, that requires some sort of formal action in terms of making sure that it is linked to criminal activity. So there's an inquiry that has to be made. If it's then decided that that money is from criminal activity, it goes to the Home Office first, and then the council do get a proportion of that back, and it has to go back into enforcement activity. It depends on how it's seized, so whether it's restrained or, I'm not an AFI, I'm sorry, so it just depends on how the cash is seized. So if it's forfeited, restrained or seized, and it goes to the Home Office, depending on how it was done, depends on what percentage we get back, but it's normally about a third, I think.
Does it seem a little bit unfair to you? Because obviously this is good work that's going on, a lot of time and effort and resources, and you've got to spend the resources in terms of disposing of it. Surely there's a case for this council, the council at the Home Office, that we should retain all that money to actually pay this to do it properly, as you are doing. It's an expensive process that needs to be done.
It is, but I can't answer that question because I don't know who sets those limits. I don't know if it's the Home Office.
Maybe that's for this committee to make a recommendation back to Cabinet that we explore that.
Yeah.
Okay.
Okay, so taking that on board then, obviously if we, as a group, I've got Councillor Noaz and then yourself, Councillor Aspie, we will take that noted to explore that in a little bit more detail, Councillor Repton, because I agree. I think we're probably just touching the outskirts of this in terms of the number of shops and the number of online issues that we're facing with this, where, you know, I know myself having teenage children, where friends of theirs have met somebody online who's selling a vape and those sorts of things, and we really are just touching the edges with this. So as much of the POCA, as you call it, is received back to us and help fund doing further work on this. And my fear is, you talked about the fact that they're looking to try and legislate this more heavily, or to put bans on certain vapes and things, is that we push it further underground and therefore it causes more problems. It's a bit like the old style of cigarettes back in the day, where it was you know, as an ex-smoker and still nicotine addict, but in a very different way. We've just got to be really careful on this from a perspective. I'm not anti-vapes, but for me, with the question around vaping was more, you know, obviously the issues that you've risen today, but also the health implications, long-term implications of absolutely getting off the cigarettes, but the impact of that going forward. And that's something I'll ask a little bit more of yourself, Jewis, if you wouldn't mind.
Yeah, so the health implications, I think what we do know is that if you're a smoker and you transfer to vaping, that will be good for your health, and it's not missing that message, because we have a number of people in the city who really struggling to stop smoking, and actually for them vaping could be a really, really good option. So it's not to forget that, and we don't want to lose that in the rest of the challenges. What we do know is that nicotine is incredibly addictive, and we do know if people start vaping, particularly if they start vaping at a younger age, that it can become challenging for them to quit, and that might become a lifelong habit. But as it stands at the moment, we're quite early in understanding what the impact of that might be, and although we can securely say it's going to be better for your health than smoking is, what we don't know is the level of damage that might cause compared to not vaping. The general message that we can only give about that is that if you don't smoke, don't vape, and that's the main message we can give. And I think over the coming years, it's going to come more apparent. And as we mentioned about the university, their concerns originally emanated from the flavours in some of the legal vapes. So it's not just the concerns around what the contents and ingredients of the illegal vapes might be, and as Donna mentioned, sometimes the doctoring of the vapes with cannabis and other drugs, which is definitely happening. But there are those concerns around some of those flavours and what the implications of that might be, and we're just not in a position to know at the moment. But my concern, particularly around the flavours and around the disposable vapes and around the presentation of the packaging, is that some of these products are clearly marketed at children. And as I mentioned, some tobacco industry companies now moving towards seeing themselves in a smoke-free future, and actually vaping and other nicotine products becoming their product to promote in the future. So that's really the concern then around how that's promoted to young people and how we can share that message around not taking up vaping if you're not a smoker.
Thank you for that. Councillor Nawaz.
Yeah, just a quick couple of things. You know, I see a lot of kids outside school, like you said, you're teenagers, and I go to pick kids up from school, and you know, you see, oh, can't we put a stop, talk to the schools and ask them not to, you know, head teachers or something like that? Can we talk to them, not bringing vapes to schools? Is there anything we can do about that?
So we are very much working with head teachers around their school policies as well. Did you want to come in, Lisa, around?
Hi, I'm Lisa Byrne, consultant in public health in Robin's team. So yeah, there has been some information already gone out to schools this term that's from OHID, the Office of Health Improvement and Disparities, which have produced some resources for schools. So they have been shared with schools. And also there's a member of the public health team who's working very closely with schools around the whole school approach. So looking at the kind of the way the whole school tackles some of these big issues. So not just like if catching somebody vaping and punishing them for that, but understanding what's behind that and some of the broader approaches that they can take to help tackle things like vaping and other things that might be similar. So some of that work is going on. Admittedly not across all schools because there isn't a capacity to do that across all of them, but in a targeted way. And as more resources come out and as more things are being developed, we are trying to share that.
The kids are mainly using them as like fashion. You know, it's not that they want to smoke or they don't do that. They just want to hold one in their hand and just use it as a fashion, really. Yeah, a lot of them do that. All right, thank you, Chair.
Thank you, Councillor Nawaz. Going back a few years, it was cigarettes that used to be the thing to walk around holding. And as a previous 12-year-old smoker, which was probably not the best age, definitely not the best age, should I say, you know, a lifetime of nicotine dependency. So I totally understand what you're saying, but we're in danger of just crossing into the children's area and the adults. And for me, yes, absolutely, those young people are going to, so it's the university element. It's sort of going back and trying to push that as they're getting into that early young people's age, whether we can understand the long-term implications of vaping, because this generation, or that generation that we're hitting now, probably didn't ever smoke, because it's not been cool for a few years, because it's the vaping that is, and actually it's that sort of next stage that we need to tackle, and what more we can do to promote the risks of vaping for that younger dynamic of young adults. So again, if any works we can do, I always say what worries me is the illegal vapes, and I've threatened my daughter that there's probably cat urine in them or something of that description, that she really doesn't want to inhale. So, you know, from that perspective, there is no legislation around what they're putting in it. So for me, it is really concerning, and the drugs aspects, passing vapes around, date rape drugs, things like that can happen, and these are very young teenagers. You know, you mentioned yourself 12, 13-year-olds, and primary, that's scary. So sorry, Councillor Ashby.
Thank you, and thank you for a great presentation. It's great to see it. It's really informative. Great to see how much action you've already taken at our. That's really encouraging because I share Councillor Ralston and probably all of our concerns. I have huge concerns about vaping and have done for some time. And having worked myself in smoking cessation many years ago, yes, we can say it's better than smoking, but I fear that, like cigarettes, you know, we all know they were dished out in the 50s for free, and then it took a long time before the danger of smoking was recognised. I actually fear that in 10 years' time we'll be saying, actually, vaping is so much better, you know, a percentage better, but actually still a huge percentage doing damage. So I really fear about that. So do we license vape shops? Because it seems to me, when I walk around the city, I mean, there's been a terrible growth in vape shops in every part of the city I've been to, which when I've been abroad, I'm not seeing that. So I don't know whether vaping is a bigger problem in the UK than in other countries. Having said that, I think about it and think, yeah, I actually saw more smokers abroad as well. So one question was whether we actually license vape shops, and if we don't, why not? Because they're becoming a scar on the city, in my opinion. You know, every other previously vacant shop seems to be a vape shop now.
Can I ask you to come in on that to update us? Is there a licensing element to the vaping?
There isn't a licensing regime currently, no. There's no requirement for vape shops to be licensed. They can be sold from any retail outlet, similar to tobacco. So yeah, the controls and the restrictions are not the same as they are for tobacco currently. And so no, I don't think there is a licensing regime. There's not one that I'm aware of. And normally the specialised vape shops are the ones that are probably more compliant than you would see in terms of your general convenience store that are hiding them in big saw boxes and all sorts of other areas. So yeah, they're popping up. It's something I have been thinking about and looking into, especially in terms of them hiding the fronts of their shops with lots of brightly coloured information. I mean, we've got a candy store not too far from here that also sells vapes, so there is no licensing requirement, but the legislation doesn't support anything in terms of us as trading standards officers being able to stop that activity unless you go for something like a closure order. And in that respect, you've got to be able to show the antisocial behaviour aspect associated with the vapes being sold from that particular premises.
I think we're anticipating a problem that is coming and something that needs to be dealt with further down the line. It may not be something that we can, as a city, initially do right now without that legislation coming from national government. If that's the impression that I'm getting, which is very sad.
I had two other parts to my question, well, two other questions. What is Challenge 25? Forgive my ignorance, but I'm always told there's no stupid question, and I always think if I don't know, there's probably others in the room who don't as well.
Challenge 25 it was Challenge 21 initially, and they increased the age range. So basically, it's a mechanism that supports retailers when they ask for identification from young people. So if anybody looks under the age of 25, they can say, we've got a policy, there's a poster, and they can ask them for ID. So there used to be a lot of abuse that retailers got from people being asked for ID. So it was a way of supporting them and backing them up. And in line with that, we normally ask them to do a refusals register. So they take details of people that have been refused a sale so that we can keep track of the fact that they are actually, there's no legal requirement for them to do this, it's voluntary, but it's something that we promote so that they can protect themselves and the young people in terms of underage sales activity.
Thank you. And finally, the illegal vapes. the mind boggles as to what's in them. Are they generally simply vapes that have a higher level of nicotine or are larger, or are they just a whole mix of cat urine and everything else included?
There's a lot of chemicals in vapes, and this is part of the work with Derby University, because we wanted to get the counterfeit vapes tested so we could see what was in them. So we used to do it for the counterfeit cigarettes, the illegal cigarettes. I think to go through a legitimate test house, it's about £500 to test just one particular vape, depending on what you're looking at. So we're working with the university to try and see, but we haven't got those results yet. But there are a lot of probably harmful chemicals within that liquid that we're probably already aware of in terms of the legal product, but how that compares and what the impacts of that are part of this particular study.
Thank you very much.
Are there any other questions? I want to thank you for the presentation. Very interesting, and if when that study is available, it would be great for it to be shared amongst the scrutiny committee. Okay. Thank you very much.
Thank you.
Okay, apologies, my screen has gone because I was so involved and interested in that last presentation, and my battery is now dead. Our next item is item 6, accident emergency waiting times and winter plan. We've got Dan Webster. Dan, thank you.
Yeah, that's right. Thank you. Good evening, everybody. My name's Dan Webster, and I'm the Programme Director for Urgent and Emergency Care for the ICB. I've been asked to come and give you a discussion around our A&E waiting times, current position, and our winter plan as well. What I'll probably do is just discuss our waiting times to start off with, which actually we'll talk about the performance, and then I'll pause, just take a few questions and before we move on into winter plan, if that's okay. So if we can just have the next slide, please. So just for a refresher, we're working towards a nationally recognised 4-hour performance target within our accident and emergency departments, which is basically a decision to admit, transfer or discharge patients to alternative care if required. So at the moment, what you'll see in the graphs and charts there is a tracked position. Our current target, as nationally set, is 76%, and that has to be achieved by March 2024. So as you'll see, we are tracking slightly above our target for the year so far, and long may that continue. And what I've also tried to describe there as well is how we sit within our regional peers and our performance targets against those. I think what we want to articulate is this has been a massive effort in collaboration between all partners within the health and care system to get us to a position where our performance is improving. But I think we need to also focus that performance is patients. So our patients are getting a much better service. They're having decisions quicker, and they're being discharged quicker from our accident emergency at UHDB currently. So we are still on a journey with our improvement. We have a comprehensive improvement plan that tracks us to get us to the position of 76%, probably earlier than 2024. And we will continue to push on with that. There are a few areas that could impact our position, such as winter, which I'll discuss shortly. But that's quite a short brief, because I think the ask was just to give an update on A&E waiting times, which is A&E performance in general. So I'll pause there and just take any questions, if that's okay.
No questions? No. Very positive to see that we are above the current target levels, obviously. So yeah.
Absolutely, and thanks to our patients as well, and our partners. It's not just the A&E that's delivering that performance. Our patients are choosing the right alternatives, such as urgent treatment centres, such as community pharmacies, such as self-care advice, and there is 111 as well. So we thank our patients in Derby and Derbyshire for choosing well as well. Thank you. So if we want to move on to winter planning. So we have a national, an NHS mandate from the government to essentially bring together our winter plan for this year. Winter planning is nothing new to the NHS. We've done it every year. I think the difference is this year we've had a really comprehensive operational plan that we've submitted to NHSE, and what we didn't want to do is detract away from that operational plan too much, because we've done that for a whole year plan. What we've tried to do with the winter plan is just make sure that we are sighted on any surge and resilience issues that historically are known, generally around IPC, infection prevention control measures, around that type of year, and normal winter illnesses. So we've already submitted our initial draft winter plan that had to go in earlier this month. That's been submitted to NHSE. We've already had feedback on that, and are currently working with partners to ensure that we're clear on what our potential gaps are. So we haven't got a published winter plan yet, because it's still in draft form at the moment. But we are having weekly meetings. Our NHS ICB board has asked for a winter planning meeting to be set up. So we're having a short group brought together every week to discuss our potential interventions that we might need to make going forward into winter. I think we're really clear that we want to keep to our operational plan as much as possible, and avoid any surge and escalation. So just move on to the next slide, please. So just as I've outlined, the Winter Planning Coordination Group is up and running and tracking our position every week. And we've actually, what we probably should note is winter planning started earlier in October. It's usually sort of moving into the end of November. So we're a little bit, started a little bit earlier this year, just to make sure that we are clearer. There are potential impacts, as I've just highlighted there, and that's why we'd like people to just draw themselves to the NHS website again and look at how to stay well this winter, and again use those IPC measures that were so valuable during the COVID period, such as washing your hands and making sure that you wear a mask if necessary, if you feel unwell, etc. So we'd appreciate everyone going to that website and just focusing on there. Just go to the next slide. These are the sort of 10 high priority interventions that we've set ourselves in the NHS, and this is national high priority interventions. Those are 10 clear priorities, but they're actually UEC recovery priorities as well. So these are things that have been in play for over a year now that we've been working against in our UEC recovery post-COVID. And that's why we're getting to the position of improved performance across services at the moment as well. So all in all, still a draft position for our winter plan, but I think we're clear on the gaps and we're working on the mitigations currently.
Councillor Repton,
yeah, in terms of COVID, in terms of the injections, how widely will the COVID injections be available? For which age groups and categories, and when will they be available?
So unfortunately, I'm not the SRO for the vaccine programme, so I can't answer that at the moment, but I can certainly take that back and get you the information.
If you could, thank you.
No problem.
Councillor Ashby.
I fully understand you're not the lead for vaccines, but are they going staff vaccines for flu and COVID? Will they be part of your winter plan? Because obviously everything can be derailed if half the staff are off sick.
Yeah, absolutely. Vaccines are part of the winter plan, not just for COVID, but for flu as well. And there are discussions with our public health colleagues at the moment just about how we also manage the potential increase in prevalence around COVID this year as well. Historically, we've been able to take other areas into account. So look at Australia. That usually gives us an indication of what the prevalence will be like for flu in the UK. It's difficult to work that out currently. I was in a winter planning meeting with the UK HSA microbiologist there last week actually, and they were finding it hard to predict when we could end up with a potential COVID surge or flu surge this year. So, which is why we really want to push on the prevention side of things.
Councillor Repton.
Something that you or Robin can actually answer, but how many people here have already had their COVID the COVID jab?
No, flu.
Flu jab. I mean, I think Robin would agree. It goes without saying, the more people that get inoculated against both COVID and flu, the lesser impact is going to be on them, their families, and the wider community. So isn't it an imperative on us locally in our health service and nationally to make sure as many people are vaccinated as quickly as possible and as widely as possible? And if that's the case, then shouldn't we be using all the influence that we have in terms of the publicity that we put out and what you guys do as well to make sure that that actually happens?
I mean, I couldn't agree more. Yeah, absolutely. Any reach you have would be amazing to get people to come forward to take their vaccinations.
I think we're preaching to the converted in this room, but Robin, in terms of historic working with yourself, I know that we've done a lot of work around COVID vaccinations and making sure that the message is received to our less affluent areas and those of not necessarily first language in English. Are we working with the NHS to do that again this year with the COVID and the flu vaccine?
Yes, so within the ICB there is a vaccine inequalities group that public health members from both the city and the county are involved in. And this is the same group that's been there for about 18 months or so that's been working through the COVID vaccine delivery, and they have also picked up the flu vaccine delivery as well. So what I would say around the programme this year, I don't know where the rollout position is, but the big difference from the COVID vaccine this year is that the eligibility is going to be starting from 65. So we've got, many of us in the room won't be eligible for the vaccine this year. So it's 65 and above, people with long-term health conditions. So those people who would normally qualify for the flu vaccine, and then health and social care frontline workers as well. So it is a smaller cohort this year for the COVID vaccine. And then the flu vaccine is the same cohort, but it's also got the children in as well, and it's all children up to the end of secondary school who are eligible for the flu vaccine this year.
And we've talked historically on this sort of thing around obviously the rationale behind that, but the wider implications of herd immunity and things like that. Have we got a better understanding of, as this progresses year on year, which we appreciate now, as you know, we're in year 4, maybe, is it, of COVID, and it's almost becoming the COVID flu, almost in the same sort of lines. Are we getting better understanding of the impact that that's going to have on us, on those that don't qualify as it stands for vaccinations?
I think we've got to a position now where virtually everybody has either had COVID or had a vaccination or had both. So it's no longer a new infection to us. So we do know that our immunity wanes over time. And I was thinking back myself to when I last had COVID and I was last vaccinated, and it was the back end of last year. So I think for many of us, it's actually some time now since we've either been vaccinated or had COVID. And what we're seeing at the moment is quite an increase in cases. It's difficult to measure because we don't have the test that we had before, but you can just see it, or don't you know people who've got it, so you can just see it around you. So we're clearly on an increase in the number of cases, and that's why it's really important to get the COVID vaccination out to those who are most vulnerable as quickly as possible, because it's definitely building the circulation within the community now. And I know there was a mention of all of those measures, but washing your hands is washing his hands is still a good idea. And then the other thing, the rules around COVID, around flu, they're not as they were. But if you are not well and you're able to stay at home, then stay at home and keep it to yourself. Really is the really key message about that.
Councillor Ashby.
Thank you. I mean, there's a couple of things, isn't there? Yes, we want people who are eligible to have the COVID vaccines, but the payment to general practice for COVID vaccines doesn't make it practical for a lot of GP surgeries to give the COVID vaccine. So a lot of GP surgeries aren't doing that now. They're simply doing the flu vaccines, which I think is a terrible shame in terms of rolling it out and getting people signed up for it, because there's lots of people going having their flu vax who would happily offer their other arm for their COVID vac if they could have both at the surgery, but they can't, which I presume that that's a national funding and nothing that we're funding locally. But could we as a council, back during COVID, there was, every time you turned on your computer, certainly in the NHS, it was reminding you of masks and hand washing and all of that. And sadly, in this country, we haven't done what they did in Asia back in 2012 when they had the first SARS. And the Asian people ever since, in some of the more Chinese countries, wear masks if they sneeze. But we haven't held on to that. I'm beginning to see a very small number of people wearing masks in public places. But could we somehow within the city promote that more than is currently happening, as was happening during COVID? Because as you say, we had less flu when everybody was wearing masks. And when a certain percentage of people were hand washing, I was still horrified if I was in a public place, whether it was healthcare or shopping, at the lack of hand washing when one was in places where one would expect adults to hand wash and hand wash properly. But there you go, that's life. But, at least if we could do what we can, maybe we can bring that back to the council to promote masks and hand washing.
Yeah, it's a really difficult one, isn't it? Because ultimately, if it's not the law, it's not a legal requirement, it's a choice.
Yes, but we can encourage.
Encourage.
Same as smoking,
Yeah,
there's evidence
absolutely.
that, when if GPs tell people 10% of people will give up simply because they're told. If we can simply increase the number who wear masks and hand wash.
I suppose my question from an NHS point of view is, a number of people I know have had family in the hospitals recently, and they've mentioned to me that there is an increase in mask wearing. Is that something that's being encouraged in the hospitals again now by staff, or is it just individuals choosing to do that?
It very much is, yes, and myself and Robin have been exchanging emails just today, actually. So our chief nurse is in conversation with the NHSE IPC lead today to just discuss what needs to happen around potential increase in measures within our facilities. So that guidance, I would imagine, should come out relatively soon. But I mean, but for me personally, I think it makes sense for us to almost practice what we preach, and I think it's helpful to protect our staff as well, especially over winter, that we should be taking other measures to safeguard them whilst they're delivering care. So I would imagine within the next sort of 24, 48 hours, we'll be able to articulate to our system partners recommendations on what they should do for IPC and mask wearing in particular.
Thank you for that, Dan. Obviously, as and when that becomes available, if you can circulate that amongst us all, I'm sure we'll all make the effort to share amongst ourselves and other council colleagues and councillors, and try and get that out in the community as much as we can on our own social medias, and encourage where we can. Any other questions for Dan? Lovely. Thank you very much for that update. So we're moving next on to item 7, which is the Making Room for Dignity programme, and that was Andy Harrison.
Thank you, Chair. My name is Andy Harrison. I'm the SRO for the programme, and my colleague Addy is the Chief Operating Officer for the Trust. So just to briefly recap, the programme was developed to eradicate dormitory accommodation in Derbyshire's mental health services, and to develop the local specialised services that we so sorely need to avoid out-of-county placements. Following the discussion and support from this board in June 21, we've been out to get the necessary capital funding for the builds and the refurbs, and the revenue funding for the safe staffing levels that are needed. We were badly hampered, I have to say, in early 22 when there was a construction market hyperinflation, which was actually largely driven by the war in Ukraine, because so much of the raw materials come from Eastern Europe. However, we finally secured the capital funding for the 2 new build adult acute units in September last year, and the funding for the remaining 4 schemes December last year, together with the necessary revenue funding to ensure safe staffing for the new facilities. The programme is progressing really well. With the new builds are already up to roof height. There are a couple of photos, I think, included in the report. And importantly for me, the builds will be watertight before the winter, which means that we won't lose any time due to bad weather. 5.5 of the 6 projects will be completed and go live for service users during next financial year, in a phased timeline, and then with the final 17 beds opening in April 2026. Due to the programme timelines becoming out of sync caused by that hyperinflation in the construction market and the extended funding approvals, the one part of the initial programme that we haven't been able to initiate was the decamp ward that supported the Radbourne refurbishment. However, our Derbyshire Integrated Care System colleagues have supported us in securing the small number of beds that we temporarily need during that refurbishment at Mill Lodge. And Mill Lodge is a trusted and high quality mental health partner. It's located 18 miles from the Radbourne unit where the refurbishment's taking place. And we have an excellent working relationship with them and are confident good levels of service and care whilst that refurbishment takes place. And that enables the first part of that refurbishment to start as planned next month. As from the outset, we continue to engage with our patients, our carers and members of staff, which we have done from the beginning of the programme. Most recently, it's included final refinements to the building designs, and indeed naming of the new buildings and the wards as is outlined in the paper. And that engagement will continue in a number of ways as outlined in the paper. So the Trust will of course continue to provide updates to the committee on an ongoing progress, and happy if members would want to visit and see the progress with the new builds to facilitate those visits and arrange a date and time if you should wish.
Councillor Repton.
Yeah. Could you give us the total number of beds currently available at the Kingsway and the Radbourne unit now, and then what you envisage after these refurbishment and new build?
Yeah. So there are 52 beds at the Hartington unit in Chesterfield, and there are 90 beds at the Radbourne unit. And in terms of the acute beds, there will be exactly the same number following the refurbishment, plus an additional 14 specialist male beds for psychiatric intensive care, an additional 8 female beds for specialist care.
Yeah, thank you. Thanks.
Councillor Ashby.
So the difference in numbers of provision for male and female, is that simply because that's what the specialists in healthcare have requested?
It's based on pure demographics. So one of the things that we are doing is the split of beds is based on the demographics of people that are accessing the services. One of the things that we have done in terms of where the beds are placed is a move of 2 beds from the south to the north to Chesterfield, simply to balance where people are accessing services from.
I have to confess I was a little surprised to read that the 2 female wards being refurbished in Radburn unit are going to take 16 months to refurbish 2 wards. When you think, not even a new build, why is it taking that long? You know, the female provision in Derby seems to be coming at the end of everything else and be taking an extraordinarily long time.
If I may answer that, I would absolutely agree with you. We have actually brought forward the female specialised beds by 4 months to make sure that those come online as soon as that building is available. The big problem that we've got with the Radbourne unit is the way in which it was originally constructed. Every single wall on the ground floor is load bearing. So what the contractor is having to do is effectively make a steel rib cage right the way throughout the building. And to answer a potential subsequent question, the reason we have to use the downstairs wards is because we want to give people garden space, fresh air and stuff. So.
Councillor Repton.
Yeah, I can remember many years ago, having to detain people under the Mental Health Act, having to ship them up to Chesterfield or over to Staffordshire. How confident are we that the aims under 3, end of out of area psychiatric intensive care unit and other placements will be achieved with this development? Or is there going to be enough to make sure there's not other people like me having to do what I had to do 10 years ago, and shipping people up to Chesterfield, out to Staffordshire, etc.? Which wasn't in their interests, obviously, wasn't in their family's interests, wasn't in anybody's interests.
Yeah, I absolutely agree. That was one of the reasons, Councillor, that a lot of work went into the demographics of where people were coming from, and hence the shift of a couple of the acute beds from the south to the north. The biggest change, I have to say, will be the introduction of the psychiatric intensive care, the specialist services, because at the moment we have none anywhere in Derbyshire. So every person that needs those facilities has to go to a different county, and sometimes in the case of where beds are available, for a particular patient, it could be hundreds of miles away, which makes it almost impossible for family members to support. So to actually get that psychiatric intensive care unit and the enhanced care unit up and running November next year, March 25 will make a huge difference. A huge difference.
Excellent news. I'd echo my concern, Councillor Repton's concerns around the number of beds, because once you add all these together, it's relatively still quite a small number of beds available, and presumably that is propped up by external providers across the city for those. The need of the city. I suppose my question is, in terms of where we're at now and where we're projected to be in the future, what is the current numbers that are being billed externally, and how will that fit in, and is there room for growth within these builds?
So I'll bring Ade in 1 second. In terms, just at a very high level, the reason for there not being a growth in the acute mental health beds is because of the development of the community services, the community mental health services. So people are being supported at a local level, and by the expansion of those services, then we can limit the number of inpatient requirements to the numbers that we've got. But Adi is much well versed in the services than me.
Oh, thank you. I think you're quite right, because what of our aspiration going into the future is to admit less number of people rather than continue to increase the number of beds. But it's also about expanding the community services. Some of you will have heard about the Living Well, which is part of our long-term plan, and that is a big project that is ongoing in order to ensure that services within the local community And again, we've tried to overlay that with the 8 Derbyshire places to make sure that we work well with the primary care as well as social care in those areas as well.
Excellent, thank you. And my final question is just around the Radbourne refurbishment. Obviously, there's staff currently in the Radbourne supporting those individuals, and if these people are being temporarily moved to another location, what is happening with those staff? Are we at risk of losing any? Are they going to be? We don't want to lose the skills that they have. Is the question, I suppose.
No, it's a really good question, but no. The lower number of beds that we're commissioning from Mill Lodge is because we are opening up additional beds in both the Radbourne unit and in the Hartington unit. So there will be the staff. Those staff will be supporting those. I don't know if you want to.
Well, as you know, we have shortages all over the country, and so we're not losing any staff at all.
I think it probably is worth saying. Sorry, Chair. One of the things that we are doing at the moment is talking and get some personal development in order to do that as an aspiration is certainly a big draw for.
Excellent. That's really good to hear in terms of staffing. Councillor Ashby.
It's admirable, of course, to plan to care for more people in the community and not plan therefore, for extending the inpatient provision. However, having not long left general practice, I'm very well aware of the actual lack of adequate mental health support in the community and the difficulty of getting patients seen, taken on. You know, the wall gets higher and higher to get patients accepted by the mental health teams. So if there's plans for more to be going on in the community, is the funding and the staff there for it? Because that's, you know, great to have aspirations, but how realistic are they?
Well, you've touched on a national problem, but that aspiration we can say because of the staffing that we don't maintain those aspirations. And one of the other things is having to work with other stakeholders. So there are a number of third sector organizations as well as other organizations that we're collaborating with a view to expand that community provision. And the Living Well project is to ensure that people are able to access services early, because if they're able to access services early, we're able to support them and ask them for that deterioration as well. But I think part of what we have to do is to keep going at it to make sure those fears that you mentioned, we can at least make a substantial inroad into getting services to everyone in the country.
Do we have evidence that the Living Well project is working? And are there, you know, how many vacancies are there in community mental health? Are they being filled?
They have, in terms of our recruitment, we've been quite successful in our recruitment over the last 6 months to 9 to 6 months. And even in terms of beginning to recruit for this new build, again, we have started on that journey already. We still have challenges in a number of areas. So in terms of the whole geography of Derbyshire, there are pockets of areas where we have significant difficulty, and there are areas where we're getting better at recruiting and having to look at other ways of ensuring that we get more staff.
Councillor Repton.
I think Councillor Ashby's raised a very important point. I mean, I remember looking back at the figures that, like Pastures, where I used to work, Pastures Hospital, Psychiatric Hospital, where we had over 1,000 patients. Now we're talking about a few dozen. Obviously, there are And that was back in the 1960s. So I guess now, with increasing the population, there'll be many thousands of people with mental health problems in this city who may or may not be getting the help and support at a level and in a timely way that they should be. So I think it's up to us possibly to have a permanent item on the agenda for us to shine a spotlight on just making sure at regular intervals that those citizens, certainly in Derby, who have mental health problems are getting a timely and appropriate response to their mental health needs. Because the fear has got to be always that they aren't. And there are many individuals and families suffering, and that's in nobody's interest at all. Theirs, their families, or the wider community, sort of in terms of their health, in terms of socially, and in terms of economically. So maybe as an item on this agenda, that's something we ought to look at and just get a health check, so to speak.
Thank you, Councillor Repton. I think absolutely, I think that's something that we should put on our agenda going forward. I think when we talk about these individuals, these are acute cases, diagnosed individuals with long-term mental health issues. And I think we're in danger of blurring the lines between the mental health issues that we have and those that are requiring hospital care. But I see what you mean absolutely, and we need to understand both of those aspects to know if that fine line isn't actually in the right location, if that makes sense. So I think if we can look to have this as a regular update in terms of once we're all up and running and everything's fantastic, the beds and how they're filled and what the waiting times is, or if you are having to use external providers, etc., but also bringing that element of community in to see what the wait times like are for self-referrals to mental health support. Absolutely, yeah, and whether that's escalating, etc., and the impact that's having. I do think there has been a big improvement personally on community help support with mental health, and I think as a the general public are more accepting of mental health and mental health awareness, and I think that's a real positive, especially within schools and everything else. More people are more aware of the implications of mental health, but this is from my understanding, is a much more acute, severe need without that support of home and community, if I'm right in my understanding. Okay, so I think, yeah, we'll bring both of those items back together at future meeting to see what synchronisation there is or lack of that we've got going forward. Thank you very much for the presentation. I personally would love to take you up on the invite of visiting as and when. We've got some lovely new facilities available and getting future updates. So thank you for all your work and efforts on.
Thank you.
Thank you. So we're back now down on the agenda to item 8, which is the post-long COVID service review, and that's Dr. Chris Weiner.
Thank you, Chair. So yes, there's a paper which has been circulated to advise people about a long COVID service review, which has started towards the end of the summertime this year, and will continue through into November. So just to give people a sense of what the long COVID service currently does, it offers a rehabilitation service for those people suffering with a complex post-COVID infection syndrome. And as many people have read in newspapers and heard on the radio and the news, this is a syndrome which is often characterised by things like breathlessness, extreme fatigue, muscular aches and pains, and often also a sense of what's described as a brain fog. So it is definitely a complex syndrome, and it requires a multidisciplinary approach to try and manage and assist those individuals who are suffering from long COVID. The service itself was set up right in the peaks of COVID in December 20, and that's when the service was initially set up. in recognition of some of the problems that people were facing after COVID infection. The service was expanded in April 22, and all of that has been done on non-recurrent funding as each year has gone through. So we're now entering a new era of COVID, where we're beginning to learn as a society that we're going to have to live with this infection and manage it for the long term. I think it's important for us to recognise that at the peak of COVID infections, there were approximately 60 people per week being referred through to the long COVID service. At the moment, it's nearer about 12 people per week who are currently being reviewed or referred through to the service. But we have around about 1,000, a little over 1,000 people who are currently engaged in the services as they're and are receiving treatment for long COVID. The review itself is, as I said, started in summer, expected to continue into November. There were 5 workshop events which have been organised, engaging community experts and also patients who have been affected by long COVID. There's a survey which was started in September, and I think all of that information is now being drawn together, or will be drawn together, to help advisors as to what do we do in the medium to long term to ensure that we've got the right services available for people who are unfortunately suffering the consequences of severe COVID infection.
It's very comprehensive reports that we were sent, and I have looked through a few of those. Are there any other questions on this? I suppose for me, it's the question for me is how accurate, how long-term implications of COVID. A lot of these symptoms that we're seeing can be related to other conditions, and especially some of the highlights that you've mentioned in women. You know, when it comes to, you mentioned brain fog and breathlessness and muscle aches. A lot of those things could be related to other areas of health, menopause, etc., things like that. How sure are we that these are, how do you differentiate between the long COVID and those other scenarios that I appreciate menopause you can rule out if they are going through, but are there any others that are sort of muddying the waters as such?
Well, you're right, Chair. I mean, there is a lot of overlap with a number of other conditions, and people will be aware of sort of other post-viral type syndromes which have been identified in the past. I think the important thing is actually that as people present with these various symptoms, that actually other treatable conditions are identified prior to to being referred through to this service or as part of that service review. So other conditions which might overlap with this do need to be excluded, and I think it's a case of that once all of those conditions have been excluded, then it then becomes a case of, well, okay, so this looks, we know there's no other treatable cause. It's occurred after a COVID infection, therefore we believe it is a long COVID presentation for that individual.
The reason I ask is things like fibromyalgia, and I apologise if I get the pronunciation of that incorrect, but those sorts of things, again, that sort of thing has always been rule out everything else, and that's what we're left with. So just the understanding of that really for me is how many of those that are referred to you do you sort of say, actually this is not COVID related symptoms?
Yeah, I mean, I can't give you the exact number. I can't give you the numbers on the number of people who are referred and then assessed as no, this isn't long COVID. You need to be referred back to a different service. But I think it is important that we recognise that the people who are reviewing patients will be aware of these other conditions. There are differences with things like fibromyalgia to the long COVID, in the sense that with fibromyalgia you get probably more of a focus on things like the muscular aches and pains, probably less of a focus on the breathlessness which is associated with the condition. So there are ways of sort of helping to try and differentiate between one and the other. But I can't give you the exact figures in terms of the numbers of people going through and whether they remain in service.
Councillor Ashby.
Having referred many people to your service, I think it would be fair to say, Councillor Ralston, there's a very strict referral criteria where a lot of other conditions are investigated first, and actually they don't even get to the long COVID clinic till you've gone through that very strenuous process with multiple blood tests, x-rays, echoes, all sorts of things that have to be done to exclude other causes. So I think they don't get to your service very often without us finding out if there's other things along the way.
Thank you for that clarification. It was just something that I just sort of, as you see all the symptoms before you, you kind of think actually.
Very, very fair question, but it is quite strenuous.
Brilliant. Are there any other questions for Dr. Chris? No? Lovely.
If I may. So can I just take the opportunity to promote COVID immunisation again this winter? The best prevention here that we have is to avoid infection, and COVID immunisation is absolutely central to try to help protect people from the complications of COVID this winter, and I suspect for future years to come.
Thank you, and I think if everybody is in agreement, I think that should be something that we, based on a couple of things we've heard today, recommendation from this board to the cabinet member, that we encourage and promote vaccinations across the council and across all our wards and individual residents. Brilliant, thank you very much, and thank you for your time this evening. Finally, I think we're on our work programme. Just checking we haven't got anything with yourself. Any questions on our work programme? Are we happy with everything that's been put in? We think it's fit for purpose? Excellent. Well, that was a lovely meeting, everybody. Thank you for a very nice evening, and I will see you all at our next meeting.